Well, we all know Reddy. He's been in this department for several years, way before I got here. Very skilled surgeon. He has a special interest in pulmonary thromboendarterectomy and has done several cases. And today he's been asked to give us a talk about chronic pulmonary thromboendarterectomy.
Yeah.
All right.
Thank you.
Sure.
Thanks, Percy. All right. So obviously, this is a topic that's near and dear to my heart. So we'll try to talk it through, and some of it will be my personal bias, some of it will be data, and a lot of it will be actually ideas that came from the recent international conference on CTEPH in San Diego. Some of the slides are from there as well, and so here we go. Okay, so we'll start with a recent case. Some of you in the audience know this patient well. It's a 58-year-old gentleman who who had a previous pulmonary embolism, acute pulmonary embolism, presented to us with progressive shortness of breath and palpitations. He was unable to walk for more than a block. His echo showed right ventricular dysfunction and pulmonary artery hypertension. His CTA, let's see if I can get this pointer working. His CTA shows thrombus here. It's clearly chronic. And the way you tell chronic from acute, so acute will look like it's sitting into the vessel lumen. Chronic will be layered against the wall. I'll also show you an example of a web. That's also a common appearance of a chronic, but this is a chronic presentation. Now this is a web. So this guy has a web. So you can see it's not that clear, but here you can see that there's a line across separating two areas of dye, and that's a classic web. All right, his preoperative hemodynamics shows a PA mean pressure of 35, and his systolic pressure is about 2/3 systemic. So he underwent pulmonary thromboendarterectomy, closure of PFO, tricuspid valve annuloplasty, which is controversial, we'll talk about it, a resection of the left atrial appendage, again, because he had AFib in the past. The circulatory arrest time for the procedure was 16 minutes for each side. That's the specimen, the right side and the left side. And his postoperative catheterization 2 months later, showing mean pulmonary pressure of 21, and the systemic, that's about 1/4 of systemic at this point in time. Okay? All right, so we'll start the talk with a question. Okay, let's start the backbenchers. Which of these is true? Previous history of acute PE is obligatory in CTEPH. A mean pulmonary artery pressure of greater than 25 millimeters with a wedge pressure of greater than 15 millimeters mercury. A wedge-shaped defect on the VQ scan. Thrombophilic disorders are common. That means they're over 50% of the time you'll have thrombophilic disorders. And CTEPH is involved with WHO Group 4. Any guesses? Multiple ones of these can be right. You don't have to be right. This is just a pretest, so just tell me what you think.
I think wedge pressure, you want that to be lower.
Good. What else?
So less than 15. I think the thrombophilic disorders are likely common.
Okay.
And previous history of acute PE, I don't think that's obligatory.
Good.
The wedge-shaped defects on the VQ scan, I don't think that's needed. I can't tell you exactly.
Okay.
I'm not sure. And then the WHO group, I don't know.
Okay.
Is
All right.
it difficult to accurately get a wedge pressure in these patients because the
Actually, that's part of the right heart cath and has to be done. And yes, it's a little difficult. You have to be careful because you have to get down to, if you have an occluded vessel, then you can't get it there. So you got to get it in a non-occluded vessel. And so yes, there is some technique involved in this, but they do have to shoot an angiogram for the most part and go to a non-occluded site to get it. And they can do it. It's quite accurate too. Okay. So we'll go ahead and try to establish which things were right and which things were wrong, right? Definition of CTEPH. Mean pulmonary artery pressure greater than 25, wedge pressure less than 15. So Steve was right, okay? In the presence of multiple chronic organized occlusive thrombi emboli in the elastic pulmonary arteries. So that's down to the subsegmental. Below that becomes capillaries, arterioles, etc. Those become muscular. They're not elastic, they're muscular. So that's not supposed to be involved. After at least 3 months of anticoagulation. So there's a time element, there's a pressure element, there's an anatomic element. There are 3 elements to this diagnosis. Okay, WHO, classification of pulmonary hypertension, it's group 4. Just remember that. That's easy to remember. Group 1 is the idiopathic stuff. Group 2 is related to left heart. Group 3 is related to the lung. Group 4 is CTEPH. All right? But just remember group 4, that's fine. It's a question that will come up, and you should be prepared for that. All right. So now let's talk about what is the incidence of this disease, because that's important, right? We need to know what we're shooting at. So if you look at it, this is the incidence of chronic pulmonary embolism 2 years after the diagnosis of acute pulmonary embolism. And look at where this stuff goes. This goes all the way from 0.4% to 9%, anywhere, all right? The most commonly quoted paper is the Pengo paper. It's a New England Journal paper from a few years ago, and there it is. So the cumulative incidence at 2 years is about 3.8%. Now, you notice that after 2 years, there's no further diagnosis of CTEPH. So if you follow patients out for 2 years and they have no sequela of their acute pulmonary embolism, then you don't have to worry about an acute pulmonary embolism becoming a chronic problem, right? Most of us will follow them for about 16 to 18 months. 18 months, we get a CT scan. If that's okay, don't worry about it, all right? So every patient with acute pulmonary embolism is followed for at least 18 months, okay?
How are they followed? Just
CTA.
CT.
CTA. CTA is the commonest follow-up is 2 ways. One is echo, and you're measuring pulmonary pressures in the echo. As you know, sometimes that can be inaccurate. And the second is anatomically, you follow them with the CTA. Usually we get the CTA at 6 months and 18 months. Okay. So now, the key question is, if this is 4%, then we should be seeing a heck of a lot of these patients with CTEPH, right? 4%, there's about 500,000 patients a year diagnosed and surviving pulmonary embolism. So 4% of 500,000 is a lot of patients. It's 20,000 patients a year. There's only about 350 or 400 of these done a year in this country, even today. Okay? So there's a huge pool of patients out there. So now, obviously, people are trying prediction scores, etc. There's a fair amount of literature around this, but there's nothing successful at this point in time. So we don't have a prediction score for who, after acute pulmonary embolism, is going to develop a chronic pulmonary embolism. We don't have that yet. Okay. Part of the problem, there are 2 problems with this. The reason is that CTEPH is only a small part of the post-acute pulmonary embolism spectrum. If you look at the spectrum, you have all patients after PE is a big circle. Those who report symptoms, even with normal pulmonary pressures, even with no anatomical sequela on the CTA, some patients are symptomatic. We don't understand why. They have an arteriopathy. It's probably a distal arteriopathy. We don't understand why, but some patients do become symptomatic. Chronically speaking, they have reduced exercise tolerance after acute PE. We don't know why. That's a larger group of patients. Then there are patients with persistent thrombi. So there are patients who don't have CTEPH, who, if you do a CTA, will show persistent thrombi, normal PA pressures, not symptomatic. You leave them alone. Okay? And then there are patients with the persistent thrombi and measurable limitations, but they don't have the PA pressure of 25 with a wedge pressure less than 15. All right? So those people are called CTED, not CTEPH. So chronic thromboembolic disease. So that's a new category, CTED, as opposed to CTEPH, which is what we are interested in, which is chronic thromboembolic pulmonary hypertension, CTEPH. Okay? Now, there are centers in the world who are now operating on CTED, not on CTEPH, because the patients do better with surgery. All right, let's talk about pathophysiology. Easy to understand. This slide is pretty straightforward, right? It tells you that there's incomplete resolution. Once there's incomplete resolution, the thrombus causes the blood, there's a physical obstruction, blood pressure goes up. There's probably some progressive reactivity of the distal vessels that also adds to the pressure going up, right? Looks fairly simple, right? All right, so we'll ask another question. Which of the following is true regarding the pathophysiology of CTEPH? CTEPH may be related to staph infection. Ooh. CTEPH is more common after splenectomy. Pulmonary veins may be involved, not the arteries. And shunts may cause CTEPH. We're talking about ventricular arterial shunts. Or ventricular atrial shunts, rather. What do you think? Try it. Again, this is a pretest. So the answers will come in the next slides, but this is a pretest. So tell us. What do you think?
More than one can be right again?
More than one can be right.
I guess B sounds
D, shunts?
Yeah.
Okay. What else? All of it. Just guess. Just guess. Wild guess is fine. Don't worry about it. Don't worry about it.
It's a hard one.
It's supposed to be hard.
I think B.
You think B? Okay, fine. So let's go through. The answer really is all of them are true, but we'll go through this. Okay. So CTEPH pathophysiology, it is not just a clotting problem. Okay? There are associated conditions such as thrombophilic disorders, etc. Ventricular arterial shunts, splenectomy, thyroid disorders. All of these things are associated with CTEPH. Role of infection. I'll show you a slide that suggests that when they look at DNA mapping of these clots, a lot of them have bacterial DNA in them, particularly Staph aureus, and particularly in patients who have shunts. Okay? Small vessel disease, right ventricle. We'll talk about it in a moment. Okay, so first thing, let's talk about thrombophilia, associated conditions, right? Now this is a European series. Remember we said thrombophilia is common, and I qualified it by saying more than 50%. This is a European series, 27.7% had thrombophilia, okay? Other series have even a lower incidence of thrombophilia, all right? So thrombophilia is not common in these patients, not common. All right, antithrombin 3, protein C, protein S deficiency factor, 5 Leiden, prothrombin gene are not more frequent in CTEPH, right? Again, little controversy, but generally speaking, they're not common. All right, so it's important to remember that. Antiphospholipid antibodies, lupus anticoagulant, very common. That's the one thing that's common. Elevated factor VIII is common, but not the thrombophilic disorders. Okay? So it's important to remember that. APS and UCSD. In UCSD, you can see 37.3% of their patients had antiphospholipid syndrome. Okay? It's pretty high. Role for Staphylococcus. 5 patients, all 5 of them had staph DNA in the thrombus. All right? The idea being that staph upregulates the TGF-beta, and TGF-beta causes smooth muscle proliferation, right? And part of that may be the reason why the thrombus doesn't resolve. Thrombus doesn't resolve if it gets organized, right? Organization is through development of fibrosis, smooth muscles. So these patients who don't resolve their thrombi have organizing thrombi, and TGF-beta may be involved, and staph infections may cause the TGF-beta not to be upregulated. Now, a lot of these patients will have distal disease. They won't have the proximal disease, the type 1, type 2, type 3, and we'll talk about those, all right, that are easily accessible to surgery. So these patients are often non-operable, but they are CTEPH. All right, post-splenectomy, same thing. It's a lot more common. Again, the RBC may be deformed, so they may stick more, so the thrombi may tend to persist more. Again, splenectomy is associated with this. Again, remember, splenectomy is associated with other thrombotic conditions too in the body. So, Okay. CTEPH and angiogenesis. Again, remember, part of resolution, how do you resolve a thrombus? Blood vessels going through it and resolving it. So if angiogenesis is disordered and the VEGF levels are low, so you may not resolve your thrombus. Okay, so that's part of the problem. Veins are involved. This was something that we didn't understand until recently. A lot of these patients have thickened venules, and we don't understand why. We don't understand the mechanism, but we know that it's associated with it. So when we go back to the pathophysiology of these things, so everything is involved. The ventricle's involved in the way it remodels. The proximal vessels are involved because they're involved with thrombus. The distal vessels are involved because they become hyperreactive. The venules are involved because they thicken, and some of them have thrombus in them too. Okay? So it's a more complex disease than we give it credit for. All right. So, an alternate view of CTEPH. So the common view of CTEPH is that everything is happening forward, right? It's happening from the RV into the main PA, into the branch PAs, etc. It's happening forward. The alternate view is it's happening backwards, that the primary problem is that you have an arteriopathy and the vascular reactivity, and because the vascular bed's closed down, the thrombus forms and the thrombus doesn't resolve. All right? Unlikely, but it could be in class 4. It could be in the distal CTEPH. That may be the mechanism. We don't know. Okay. So we have an evolving understanding, right? Again, so all of these things are involved. This is an acute PE. There's elevated pressure. It doesn't resolve. Thrombus doesn't resolve. They have functional limitations, and then there's a final hit. What that final hit is difficult to say. The final hit may be an additional thrombus. The final hit may be that the RV fails. The final hit may be that suddenly there's vasoreactivity that is added on all of this stuff. So any of those things could be the final hit that pushes them into CTEPH. Okay, so that's pathophysiology. So to go back to it, all of those answers are correct, right? Staph could be involved, right? Shunts are involved, splenectomy is involved, thyroid disease is involved. All of these things can be involved, okay? And the veins can be involved too. All right, so clinical manifestations. Maybe asymptomatic for years, and we've seen most of the patients, pretty much all of the patients we've seen have had this for years, except the patient that I presented had it for about 8-9 months. But all of the others have had them for years and been underdiagnosed or misdiagnosed. Physical exam findings, very minimal, right? Essentially, you have an accentuated P2, and you may have bruise over the anterior lung fields because you have obstruction and you have blood flowing past obstructions. We've heard it once, all right? One of the patients had it. Dyspnea, exercise intolerance, chest pain, presyncope. That's late, okay? So clinical manifestations are pretty straightforward. Essentially, somebody has unexplained respiratory dysfunction. Unexplained respiratory dysfunction. So they don't have COPD. They don't have anything else that causes cor pulmonale. They have unexplained dysfunction. Then you have to investigate them. Okay? All right. Why are we interested in this? I want you to look at the top line. So this is young patients in the 50-year-old age group, all right? The dotted green line is the expected survival of the age group 40 to 50 years, all right? And then it's broken down when the pulmonary mean pressure is less than 20, look at the survivors, way up on top, right? And then as you come down, if your mean pressure is greater than 50, you look at your 5-year survival is in the 10% range, right? So that's important to remember. Pulmonary hypertension, that's the reason why we want to go after it, because pulmonary hypertension kills you. It's not just something esoteric that we're interested in, but it does kill you. Okay? Okay. Which of the following is true? CTEPH shows wedge defects on VQ scan. I think you answered that one before, but you answered it again. A pulmonary artery sarcoma may mimic CTEPH. Normal pulmonary vascular resistance is 500 units. And normal VQ scan rules out CTEPH. And you need to be able to answer these questions because you've seen all of this.
same trick as before where multiple can be right?
Absolutely. Multiple can be right.
Okay.
And multiple can be wrong too.
Okay. You can have defects on the VQ scan, but it doesn't necessarily rule out CTEPH. I think I could.
Pick an answer.
All right, so I think A is true.
Okay.
I think B could be true. Maybe.
Okay.
C is true. I think D is false.
Okay. So D is false, C is true, B is true, and A is true.
C, I mean, I got wrong.
Okay. What do you think?
I think they're all true.
You think they're all true? All right.
Yes, I think they're all true.
They're all true.
CTEPH will give us a weird difference on VQ scan. A VQ scan is a non-specific, not the gold standard test, so that is normal. D doesn't mean it's there's no CTEPH.
Okay.
Sarcoma should mimic
All right.
picture of PA.
Okay.
So I think all of them are true.
All of them are true. Okay.
I thought A, may not true. Sometimes doesn't show defect, and B could be true, C true, D I don't think.
Okay. All right. Let's go through. Let's see what we are.
You said,
All right. So,
you said in your office before, normal VQ scan rules it out.
there you go. That's it. Okay. Right. So the workup of a CT scan, a CTEPH, right? First, you suspect it by doing an echocardiogram. So the echocardiogram shows you whether or not you have pulmonary hypertension, right? Right off the bat. So you get screened into CTEPH because you have pulmonary hypertension, right? Without pulmonary hypertension, CTEPH doesn't enter the thinking, right? Now CTED could, but CTEPH doesn't, right? Okay. So then the VQ scan, and we'll talk about that in a moment. Then you confirm it by right heart catheterization and by pulmonary angiography. Now, we use CT pulmonary angiography. We don't use the routine pulmonary angiography. Again, depends on the institution where you are and where the skill levels are. Some institutions are very comfortable with pulmonary angiography. We're not. So we use CTPA. And then finally, you have to assess risk, right? So the hemodynamics, comorbidities. So if somebody has cor pulmonale, somebody has bad COPD. We've had, I think, 2 patients with bad COPD that we've turned down, right? Because, even after you treat the CTEPH, they're going to still have the COPD. And we are still too young in our evolution as a center for us to get involved in that, okay? And finally, the surgeon and CTEPH team experience, which is the most important thing. Okay. Now, so the way you differentiate CTEPH from other forms of pulmonary hypertension, CTEPH has wedge-shaped defects which are related to thromboembolism, right? When you have occlusion of a pulmonary artery branch, the distribution of a pulmonary artery branch is wedge-shaped, and therefore you have wedge-shaped defects. Okay? So that's right. Idiopathic pulmonary hypertension, see, it's uniform decrease. It's not a wedge-shaped defect. Okay? That's one of the ways you differentiate the two. All right. Pulmonary angiography, CT pulmonary angiography, you can see this is occluded. There's thrombus occluding it, thrombus occluding it. You guys have all seen examples of this. Acute versus chronic. Again, these are all examples of chronic, and you can see here it's layered against the wall. There's nothing sitting in the wall as a filling defect. It's layered against the wall. You may have a web, right? These are chronic appearances. The acute appearances, usually it has a convex. So it looks like something convex. So when you look at it occluding a branch vessel, it's a convex thing. So there's a filling defect, and it sits out convex, whereas these are concave. So you can see here, let me see if I can get you a good concave one. Probably something like this. See, this is concave, whereas in the acute it'll be convex. Same thing, pulmonary angiography. Again, you can see a cutoff here. You can see a web here. You can see a cutoff here. So, conditions that mimic CTEPH. And Steve, you actually had one of those when you were on the service. Pulmonary sarcoma. Okay, Mr. Whitfield. All Okay, so here you go. The key thing here is, look at the PET scan at the bottom. PET scan lights up, right? Everything else looks similar to a unilateral thrombus, right? But the PET scan lights up. The PET scan will not light up in a, yeah, go ahead.
How do you know when to order a PET scan?
So there are some clues. When you see a unilateral distribution like this, when you see something that's often associated with a mass in the lung as well, all right? The presentation is usually not just perfect. I mean, the patient presents as an acute PE, but it's really not an acute PE. And you're looking at it and you're saying, boy, there's something weird here. Then you get a PET scan, okay? But yeah, we've gone in after an acute PE, thinking it was an acute PE, gone and found a sarcoma, okay? And we've done that.
Then what?
Yeah. And then what? You just back up. There's nothing else you can do, all right? Okay. Pulmonary vascular resistance, normal is 240, okay? Not 500, 240, all right? Okay, it's important to remember the two numbers there that are important for you. The mean pulmonary artery pressure, less than 25. That's a number it's got to stick in your head, less than 25, all right? For the purposes of CTEPH. Now, normal mean pulmonary artery pressure is less than that, but for the purposes of CTEPH, 25, okay? And normal pulmonary vascular resistance, 240. All right. So, which of the following statements is true? CTEPH is surgically curable. Current mortality rate for pulmonary thromboendarterectomy is 2 to 4%. Circulatory arrest is commonly 40 minutes aside. Only a few segments need to be cleared.
I think B is correct. I think C is, well, you can have circulatory arrest up to 40 minutes. Not necessarily you will need all that, but
Okay.
you can do that. I think the major segments have to be cleared, at least.
Okay.
But you can clear as much as you can.
Okay.
And the same applies to A. Yeah, I would say true.
Okay. You agree with her?
Yeah, I think it's true.
So all are true.
Do you need like 40 minutes for each side?
You tell me.
20 minutes is
Well,
You said
seems to be a
16
little
at
too
the
long.
beginning.
D is definitely false. D is definitely false.
Good.
A type 4 is not surgically curable.
You should
Okay.
have operated on
So
40
not
because
all
it's-
CTEPH is curable.
Yeah.
And circulatory arrest is not 40 minutes.
Okay.
And I thought the mortality was double that.
Well, in the old series, in the new series, it's all under 4%. And it's fantastic what the mortality rates come down to. So that's important. So the most important thing is, as a general statement, CTEPH is curable, okay, including group 4 in the hands of people at UCSD and Papworth. Those guys are already doing it, all right? For us, I wouldn't tackle that at this point, but once you have a lot of experience, guys are tackling it, okay? All right, good. Okay, so factors considered in CTEPH operability assessment. Look at this. This is extremely important. Obviously, imaging is important. Imaging is key. If you don't have good imaging, you can't do this. Surgeon's experience, extremely important, right? You have to know what you're tackling. This stuff is not easy. Remember, we almost couldn't see the plane, right? I mean, it's an imaginary plane often. Hemodynamics, obviously, are important. Clot burden, if you don't have a good sized clot burden, it's difficult to go after it. The center's experience. Now, a good center is considered something that does 20 cases a year with a mortality less than 10%. Cleveland Clinic just presented their series. They do approximately 15 per year. All right? So there are not too many good centers. Okay? San Diego does about 150 a year. Papworth does 250 a year. So those are the big centers. There's a center in Turkey that does about 40. There's a center in Germany that does about 100. But that's it. All right? So everybody has low numbers, so everybody's learning, except for those centers that have been doing this for a very long time. Very important to understand. Okay? All right. Now, as part of the same operability thing, and I'm just trying to illustrate to you how even at experienced centers, if you look at this, even at experienced centers, only 12 to 60% of the patients are accepted for surgery. All right? So they're reviewing a lot of patients and turning them down because the experience with this is not large enough. Now, if these same patients were sent to Papworth, maybe 80% of them would be accepted. Okay? Or at San Diego. But as a less experienced center, you have to be more selective. Okay? All right, what are the challenges? There are very important challenges in doing this surgery, right? The most important thing is the bronchial collateral flow. And those of you that have been in on these cases, you know that until we go on circ arrest, the flow into the pulmonary vessels is torrential. Because there's obstruction to forward flow in the pulmonary system, the bronchial collaterals really hypertrophy, right? Because the lung has to be viable, otherwise the lung will be dead, right? Lung has to be viable. So because the bronchial circulation is so bad, you can have a liter of flow coming back in your face, even though you have the right side completely isolated. So that's the reason why you have to go on circ arrest, or you have to put an occlusion balloon into the aorta, one of the two things. Okay? So most of us don't use an occlusion balloon, so we use circ arrest in this situation. Okay? So bronchial collateral flow. Isolation of the right heart is difficult. Even with all of the isolation, you still have to put a pulmonary arterial vent while you're doing the right side, because there's still so much non-coronary collateral flow coming through, right? It's important to remember. The dissection plane, as you saw, Javier, is very difficult sometimes, right? On some of a couple of the examples we did, they were pretty straightforward, but some of them are very, very difficult to find the dissection plane. Thin walled vessel, so obviously if you're not careful, you tear it, you rupture it, and you can create trouble. Right heart dysfunction, so this has to be managed perioperatively. Can be rough. And finally, pulmonary parenchymal disease. A lot of these patients have parenchymal disease, have COPD, have other things that are also involved in the pathophysiology of this patient. Okay? Somebody may have a splenectomy, somebody may have something else. So those are things that we have to watch out. Okay, so the overview of the surgical technique. What do we do? People have done it through a thoracotomy. The problem with that is you do a unilateral procedure and the incidence of unilateral pulmonary edema goes way high. All right, so most people will not do that. It's a median sternotomy procedure. Bicable cannulation. The important thing about this bicable cannulation is it has to be well away from the field. So if you remember how I cannulate, I either cannulate through the atrium, pass it into the SVC, or I cannulate high in the SVC at the junction of the innominate with the SVC. It's pretty high up, okay? So that it's out of your way, otherwise it'll be in your field and you can't operate. Hypothermic circulatory arrest. These guys go down to 20, we usually go down to 21. You can go down to 18 if you want to, but all right. Most of the time you need 20 minutes per side. That was you. 20 minutes per side is what you need, okay? Not 40 minutes a side, all right? Tricuspid repair, questionable. The San Diego guys don't repair it. A lot of people don't repair it, but that's true of any valve disease, right? A lot of people don't repair the tricuspid valve. I think our bias, certainly my bias here, has been to repair it, you know? It takes an additional 10 minutes. You're warming the patient up for an hour anyway. You got plenty of time. Just take care of it. It's not a big deal for us. That's been my bias, but the bias in the literature is not to repair it. Okay? IVC filter, again, there's controversy and we'll go over that in a moment. Closure PFO, absolute, you have to, because the right side of pressure is increased, you have a right to left shunt, you got to be careful with that. Finally, complete clearance of the vessels. You cannot not clear the vessels completely, and this is where the surgical literature diverges from the balloon angioplasty literature, right? You got to be complete. All right, let's go back here. So here, technically, so this is the aorta, this is the SVC. So either you can move the SVC to the aorta, or you can move the SVC away from the aorta. It's much easier to move the SVC away from the aorta. You have a lot more room to work in. You can make a more proximal incision. You can start your dissection plane more proximally, so you have more of a handle on the vessel wall. It's much easier to do that, so pretty much all of us, most people who are doing this will do it with moving the SVC away from the aorta, all right? Then the incision is made. on the main right pulmonary artery and travels down onto the lower branch, right? So you go to the lower branch. On the left side, you start on the main pulmonary trunk and then travel down to the lower pulmonary artery. All right, so these are the various levels, okay? Level 1 is in the main branches, right? Right main and left main. Level 2 goes down to the lobar branches. Level 3 is segmental, and level 4 is subsegmental, all right? Now, this is a slide from Mike Madani's group, okay? So those guys are able to go down to level 4. We won't even try right now. We need to do a lot more of these before we can try to get down there. Current mortality rate, 2.2%, 4.7%, 1.4%. Okay? This is the 2.2% is the San Diego group, and they've done probably 1,700 of these at this point, so they have the best series. Okay, what about long-term survival? The conditional survival is if you normalize the PVR, then the survival at 10 years is 85, 90%, right? Contrast that to the 5-year survival of 10% for somebody with a mean PA pressure of 50, right? Contrast that. So clearly this is a procedure that works, okay? Insertion of the IVC filter, this is a slide from the San Diego group, actually from Dr. Fidula, and essentially they are doing it selectively. For us, our program is so small that it makes no sense for us not to put this darn thing in. It's a simple enough thing to do. Every one of our patients gets an IVC filter, period. Okay? We usually leave them lifelong and the problem with this, and that's a great question.
There's some articles like that.
Yeah, there's a great question because if you look at IVC filters, there's early complications, late complications, right? There's complications of insertion, that's immediate, right? And then for the first 3 to 6 months, there are no complications after that. It's beyond that you start getting complications of migration, additional thrombosis, particularly of the lower extremity, thrombosis of the IVC. All of those things happen after 6 months. So the bias is to put in a lot of retrievable filters and retrieve them at 6 months. So for the acute pulmonary embolism, that's what we do now. We put them in, retrieve them at 6 months. Okay? So we're getting the best bang for the buck for the acute. For the chronics, obviously we are worried that if they have an acute pulmonary embolism episode, they're going to persist again. And so in that situation, you can't take the chance of having an acute pulmonary embolism episode, so we are just leaving them in. The literature, it's just the way it's been done. Has there been a study between putting them in or not putting them in? No. But it's just the way things have been done. Okay, balloon pulmonary angioplasty. I just put this up here for reference because I think that you're going to hear more about it. Right now, it's not ready for prime time, but they're getting a lot better. In Japan, there's a guy by the name of Matsubara who's done about 400 or 500 patients over the last 5 years, okay? And the reason why it works, very interesting. If they look at this chart, which shows that only a small number of segments have to be cleared. So you have to remove a small amount of obstruction for the PA pressure to drop a lot. All right? That goes in the face of the surgical literature, which says you got to take everything out. Whereas these guys say that if they open 17 segments, they have a normal pulmonary artery pressure. So 17 segments they usually do in 3 or 4 sittings. It takes them about 4 or 5 hours each time. So it's just like, atrial fibrillation. It takes 6 hours each time, go 5 times, and they say, yeah, we're successful. They are. Patients love it, right? But it's coming. So it's something that we got to think about and keep an eye on. We don't know. It's not ready for prime time yet. There's a couple of guys who are doing it. But in this country, the experience is probably a total of about 50 patients. So it's not there yet. Evolving treatment algorithm, right? So bottom line, CTEPH diagnosis, you continue lifelong anticoagulation, right? Lifelong anticoagulation. Operability assessment by a CTEPH team. If it's operable, you go to endarterectomy. If it's inoperable, the recommendation now is get a second opinion with a more experienced team, right? Because it may be operable there. And then, if the patient is symptomatic who continues to have pulmonary hypertension after the this thing. So 90% of the time the pulmonary hypertension goes away, 10% of the time it doesn't. So then they get placed on targeted therapy, right? And then lung transplantation, of course. Yeah, and the balloon angioplasty is a little box in the back there, which is going to become a bigger box at some point. Now, word of caution, there are complications, right? The thing that we're all worried about is rupture, right? Now, these patients, if you rupture the pulmonary artery, these patients will often die. So in those situations, hopefully it's unilateral. Hopefully you can localize it. Hopefully it's lobar. You can localize it to a lobe. You occlude that lobe. Correct the anticoagulation. Sit tight. Wait. You may have to put them on ECMO for a day or two. Some of these will seal. If they don't seal, they die. All right? And that's the problem with these. Second, this is a patient with post-PTE perfusion, pulmonary edema, right? These can happen early. These can happen 2-3 days later, right? We had one patient that developed this. That was the one that you and I did, all right? Now that patient developed this and resolved over a period of time. We didn't have to go on ECMO or anything of that sort. Just needed a tracheostomy, all right? Eventually got better and was fine. And so these are things that you have to watch out for. So it's not a freebie. It's something that you've got to take with a real word of caution. All right.